Good afternoon, everyone. Welcome to session 2 of the Lurie Children's Pediatric Virtual Roundtable Series with the Potocsnak Family Division of Adolescent and Young Adult Medicine. My name is Chad Worley. I'm your moderator for this session, and I am the Lurie Children's Physician Liaison for the City North and Northwest Suburbs. I'm joined by my colleagues Paula Nowak and Julie Kalkbrenner. In this session, we will introduce you to Dr. Lisa Simons. She will discuss identifying and screening for suicide risk. The Division of Adolescent and Young Adult Medicine provides comprehensive services to adolescents and young adults. We accept new patients between the ages of 12 and 22 years. All patients are followed until their 25th birthday. In the screen here, you see our Lurie Children's Outpatient Services at 1440 North Dayton. This is an outpatient service location for adolescent medicine and psychiatry and behavioral health. For those of you who are not familiar with our new RAMP website, RAMP is a mental health care reference, resource, and curriculum for pediatric clinicians. It is formed by a group of mental health specialists partnering with pediatric clinicians to expand access to mental health care. For more, you just go to the site and visit ramp.luriechildrens.org. At Lurie Children's, we are relentless in our pursuit of healthier future for every child. We exist to help all children reach their fullest potential. Respect All is a commitment to create an environment in which all members of our community to create an environment in which all members of our community feel seen, heard, and respected, to act on all racism, discrimination, and harassment concerns raised by the patients and families we serve, and by our staff and volunteers. Lastly, I would like to remind you that this session is being recorded. We encourage you to type in your questions, and we will try to get to most of them at the end of the session for a live Q&A. But due to our large audience, we will not be unmuting the audience to take live questions. Now I'd like to turn it over to Dr. Lisa Simons. Dr. Simons, all yours.
All right. I'm going to start sharing my screen.
Great.
Hang on. Oh, not yet.
Not yet, because I am stopping sharing right now.
Okay, hang on.
Thank you.
No problem. All right. Am I sharing my screen yet with folks?
Yes, we see your screen, but you're not in, there you go. You're in presentation mode now, so you're good to go.
Okay, perfect. So it looks good to everyone?
Yeah, we'll look great.
Great, thank you. So thank you so much for inviting me here to talk about this really important topic. I wanted to first mention that these are my plans. I've been told I have 15 to 20 minutes to discuss kind of the nuts and bolts of number one, youth suicide, recent trends. I want to cover the rationale for moving towards universal suicide screening. We'll talk briefly about some tools that are commonly used for suicide screening and suicide risk assessment, and then discuss different components of safety planning. So it will come as no surprise to anyone on this call that, that in 2021, the AAP, the American Academy of Child and Adolescent Psychiatry, in the Children's Hospitals Association came together to declare a national health emergency in mental health. And I'm sure that is something that all of you in your practices have been feeling in one way or another. This really called attention to the alarming rise in mental health problems, which were really only exacerbated by the COVID-19 pandemic. So we saw higher rates of mental health problems across the board, including depression, anxiety, eating disorders, and suicidal behaviors as well. And what I want to call attention to on the right side of the screen was a study looking at youth suicide trends over time. And on the x-axis, you'll see suicide rates per 100,000 of the population. And on the x-axis is the year. Data points are in blue for males and orange for females. And this information was stratified by age. And what you'll notice is that the increase in suicide rates have been steadily increasing at least since around 2005, 2007. So after peaking in the early 90s and steadily going down, you'll see the curves turn upwards. And you'll notice that this uptick is steady and persistent and started well before the COVID-19 pandemic. And so what we're noticing is that these are really the increased rates that we're seeing right now, and those that were exacerbated by the pandemic, really occurred in, a setting where the rates were steadily increasing. And I think this is what is really contributing to the national emergency that we see today, bringing us to a situation where suicide is the second leading cause of death for youth ages 10 to 19 in the United States. Some of you may be familiar with the Youth Risk Behavior Survey, which is a survey that's conducted every 2 years by the CDC, monitoring a number of different adolescent health risk and protective behaviors that spans from smoking and substance use to physical activity. And it also captures data on suicide. It surveys students in grades 9 through 12 in every state, some provinces, and some major cities. And this data that you'll see here was taken from one of the more recent surveys, again, 9 through 12th graders, who were asked questions related to suicide. And in the red box, you'll see some of the answers from the most recent years. So asking those who seriously considered attempting suicide during the 12 months before the survey was administered, almost 19% of students responded that they had seriously considered attempting suicide. Nearly 16% noted that they had made a suicide plan in the 12 months before the survey. About 9% of all 9 through 12th graders had attempted suicide, and about 2.5% made an attempt that was brought to medical attention. So those are some pretty staggering figures right there. I want to briefly mention this, though this can really be the topic of a whole different conversation, that there are significant disparities in both suicide and suicide behaviors, disparities by race and ethnicity, gender identity, sexual orientation, and geographic location. For instance, rates of suicide among Black youth have risen much faster than any other racial and ethnic group in the past 2 decades. Native Americans have the highest rates of suicide. We see LGB and especially T, transgender youth, being at exceptionally high risk for suicide. And suicide rates tend to vary and increase in areas that are less dense and more rural. And I also want to point out that not only are there disparities in who is experiencing suicide and suicide behaviors, but also significant disparities in who has access to timely and evidence-based treatment and engagement in care. This is a table that gives by age stratification the leading causes of death in the United States, and this is from 2020. This is a statistic that I don't think has gotten enough of the headlines. So again, in the age ranges of 10 to 14 and 15 to 24, you'll see that suicide has been and has remained a top leading cause of death. What has happened in the first time in history, I believe, is that you'll see suicide is now amongst the top 10 leading causes of death for the age group of 5 to 9. And really seeing this really gave me great pause. So with all of this, well, with the increasing rates, seeing younger children also experiencing issues with suicide and suicidal thoughts and behaviors, in March of 2022, the AAP, partnering with the American Foundation for Suicide Prevention, published a call to action and a blueprint that was really, designed to support pediatric health clinicians working in all different settings, helping advance equitable suicide prevention strategies. So this website, if you haven't been on it yet, I would say offers a lot of really good resources, tools that are linked to some of the tools that we're going to be discussing today, lots of background information on suicide healthcare as well. And in this blueprint also, the AAP announced its changes to recommendations for suicide screening. So updated AAP recommendations for suicide screening are listed here. One of the biggest changes being that youth ages 12 and up, now moving from targeted screening, targeting those that clinicians felt were at higher risk, to universal screening. And we're going to outline some of the rationale for that change. One is that healthcare providers we know have trusted relationships with adolescents and young adults, but sometimes don't recognize those who are at risk. It'll come as no surprise to any of you that often adolescents do not come in, come in for many different reasons and not always saying, hey, I'm struggling with mental health, or thinking or saying out loud, I'm having, these thoughts about suicide. And we know many people who have completed suicide have had contact with a healthcare provider, sometimes in the weeks and months prior to their suicide or their suicide attempt. I think another question is, hey, we're screening for depression. Isn't screening for depression enough to detect those at risk for suicide? And I would say emerging data suggests that the answer to that question is no. So this information that I have here comes from a study that was conducted by Lisa Horowitz at the NIMH, really seeking to validate the ASQ as a tool. And as they were doing that, they queried 600 inpatients who were aged 10 to 21. This was kind of one of the first uses of our studies of universal suicide screening, and they were focusing at that time on medical inpatients. And they also thought to ask the question, well, how much would we pick up if we were only using the PHQ-A, the PHQ that's modified for adolescents? So what they found from this study is that 81 out of the 600 inpatients, that's this circle over here, screened positive for suicide risk using the ASQ. However, 39.5% For 32, this portion over here of those who were positive for suicide risk did not screen positive for depression. And additionally, 55% of those who were suicide risk positive did not answer yes to the question on that relates to suicide on the PHQ-9. And you'll see over here that 26 of the 81 who were at risk for suicide answered both no to the PHQ-9 answer and did not screen positive for depression at all. And so that suggests that if we're only using the PHQ-9 to detect suicide, we'll be missing a significant portion of those youth who are at risk. So I want to jump into some suicide screening tools and assessment, and we can get to more specific questions about these in the Q&A. But I first wanted to introduce and remind folks that the point of screening is to identify those at risk. And the point of the assessment over here is really more to measure risk and formulate a decision about who needs greater assessment and how to make a dispo plan for those people who are at risk. So the brief screen is meant to be to take about 20 seconds, and the BSSA, or the brief suicide safety assessment, which is the risk assessment tool that we're using at Lurie, is meant to take about 10 minutes to conduct. These are just a few examples, and here we'll be talking about the ASQ of screening tools, but I just want to throw it out there that the ASQ is not the only suicide screening tool. This is the Columbia on the side, but there are other screening tools as well. But we're going to focus on the ones that Lurie is currently using. So you may already be familiar with the ASQ questionnaire, the Ask Suicide Screening Questionnaire. This is a very quick survey that could be administered orally or via paper. Asks 4 questions that you'll see over here. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or a family or your family would be better off if you were dead? In the past weeks, have you thought about killing yourself? And have you ever tried to kill yourself? If any of those 4 questions are positive, then we move to the 5th question, which is, are you having thoughts of killing yourself right now? The idea is that if the last question is positive, that person is moved to imminent or very acute risk. We've got to take safety precautions in whatever the setting is. And likely this person will be referred to the emergency department for a full psychiatric evaluation. I'll say that on the NIMH Youth ASQ Toolkit site, this screening tool is available in many different languages. If it is positive, then that's when we're going to more of the risk assessment. So I'm going to quickly go through these, but this is just to show you that on that toolkit, there's also some really nice scripting that is meant for nurses to give to the parents, to introduce this parent guardian flyer, kind of introduces the new idea of universal suicide screening and aims to kind of dispel any qualms, because we know that there's a lot of, this can be a sensitive topic. So giving some people some insight into why we are answering these questions, asking these questions are important. So this is the brief suicide safety assessment. Again, I'm not going to go through all of these, but it's available on the NIMH website. It really guides the clinician. And here again, this is conducted by a clinician, either a pediatric provider or a social worker, who's really going through a lot of questions, asking about the frequency of suicidal thoughts, asking this person if they have made a suicide plan, getting more understanding about what past behaviors have been, because certainly past suicidal behavior is a risk factor for future suicidal behaviors. Asks about current symptoms, what are social supports and stressors, really digging into things like relationship problems or bullying or things that can be protected as well will be important when we're formulating risk. And at the end of this safety assessment, really the outcome is to formulate a level of risk. Is this person low risk, intermediate, or high risk? And that really kind of guides us to what is needed next. So that can look like an emergency psychiatric evaluation for those who are at imminent risk of suicide, those who require further evaluation of risk or connection to care. In those cases, we're going to create a safety plan, send the patient home with a mental health referral as soon as possible, if it's not the case that this person is already engaged in care, in which we make sure that there was contact with the treating mental health clinician. And then the outcome of that BSSA can also be more non-urgent follow-ups. So reviewing the safety plan and setting home with a mental health referral, but maybe in this case, it doesn't need to be an urgent mental health referral. I think we know our patients well, so things to keep in mind as we're making this final assessment is this a change from the patient's baseline? Do we know this person to have had chronic passive suicidal ideation, and today it's looking and sounding a little bit different? And is there anything that we can do here by way of connection to care, restricting access to lethal means, and formulating a plan to modify their suicide risk? Briefly, this is a suicide risk decision pathway that is a work in motion in adolescent medicine. So we are in the process of piloting universal suicide screening in our clinic right now. And I wanted to take the last minute or two to really talk about safety planning and lethal means counseling, and really thinking about that as an intervention in and of itself. So, as part of the background to kind of explain to patients and to families, why is it important to create this safety plan? It's important to understand the suicide risk curve. And what that really shows is that people at risk for suicide are likely to experience changes in their level of risk over time. So their risk can increase and decrease. And the goal of safety planning is really to get folks to be able to identify their warning signs before crisis occurs, and really kind of identify tools and strategies, know who's around to help them to reduce that acute suicide risk. And so the safety plan creates a tool for both patients and their caregivers to really recognize what kind of strategies may be helpful. This is a picture of one of many safety plans. This is called the Stanley Brown, and this is the one that we're going to be using in our clinic. And I'm breaking it down on this next slide. So again, the first step, and this is something that's done with the patient collaboratively, is to ask, how will you know when the safety plan should be used? What are the warning signs that you get before you notice an increase in suicidal thoughts? What's going on at the time? Have you noticed any trends? Are those like times where you just had a breakup, times when you got in an argument? Have you noticed it's times where you haven't, like when you're feeling a certain way, feeling more down, or when you haven't had much sleep? So really writing out that, like, when am I going to use this is really helpful. And then asking, well, what are the things that you can do to help yourself when you have those urges? And, really, again, really helpful to get as much, if you can, from the patient. So really, like, What's been helpful for you in the past? Distractions with music, with coloring, taking a walk outside, playing with your pet. What are those things that make you feel safer? Then identifying social contacts who can help them distract, who or what social settings, where, can help you take your mind off. Oh, I like being with my cousins. I like walking to a cafe. Those are things that, again, can get someone feeling a little more safe and stable. And then if that's not working, who among your family or friends, and here I would put a caveat, adult friends, right? We don't want to give other adolescents this responsibility, but who are other adults that you could contact for help during a crisis? And we list those people out by name and phone number so that they are readily available. The safety plan also has kind of embedded professionals and agencies that can be reached, and then also comes with some tips about making the environment safer. So another part of this discussion is really talking to the adults separately, asking again about access to firearms or other weapons. And because teens are pretty good at finding things, we really recommend removing those whenever possible. Or if it's not possible, what's a safe way to lock those away? So those can be things like certainly any firearms, talking about firearm storage, again, removal if possible, pills, household cleaners, and then addressing other things that may have come up in the discussion about assessment. And then a big, powerful, tool is just that increased monitoring. Hey, we're going to make a plan for you to be checking in, especially if we're waiting for, or as we're waiting for linkage to care. And then finally, these are some websites and tools that we use a lot of. Again, the RAMP website is incredible, and I would say that it has wonderful curricula for providers, but also has awesome handouts and videos that you can give to patients and caregivers as well. And these are some of the suicide hotlines, some that comes with texting capabilities, because I've had some folks say, hey, I'm just not going to get on the phone with someone. So texting can be an option. And This Means Matter is a website that has a lot of good information about lethal means restriction. So those are things that we found helpful. And then I just added my email as well for specific questions. Feel free to reach out.
That was outstanding. Thank you so much for your time on this, Dr. Simons.
Of course.
It was great. We have some questions coming in. Julie, do you want to take a shot at those?
Sorry about that. Sure. I'm sorry. Yeah, before we get into the questions, Dr. Simons, if you could just give your email address. It's just not showing up on the screen. And then I can.
Sure. Oh, sorry.
Sure.
Oh, I see it here, Julie. So
it's right over here, this L. Simons.
Okay.
Children's.
All right. Thank you so much. So we have a couple questions from Dr. Unger, and she's wanting to know if we can use pre-screening through MyChart and Epic. And if so, how can that be confidential?
Yeah, so I think that becomes a little bit of a risk issue. I think my concern with that is we're going to get a positive, and then what happens if and when we're not able to identify like the location of the patient or really follow up to further assess risk. So the ASQ is certainly available in Epic. And if I'm on a telemedicine call, I can send it to them in real time, but I tend not to give it to them unless we are in the encounter. And it's a good question about whether that actually increases risk or not, but I think it does if it's the case that someone answers positively and we're not able to reach them. I think it does create quite a conundrum and concern about like how far are we going to go, safety measures? Are we going to have to send the police out looking for this young person?
Mm-hmm. Okay, thank you. You had just mentioned telemedicine or telehealth visits. Do you use those frequently in your practice?
I do. Yeah, I think it's a little provider dependent right now in terms of in our division of how many people are using them. But I think all of us use telemedicine to some degree. And I mean, gosh, mental health is something that I think really lends itself to telemedicine if it's, if it's something that the patient feels good about using as well, and if they feel like they're in a space where they can speak confidentially. But yeah, we use and I certainly use telemedicine a lot, and I do use Epic to send out those screening tools, just not the ASQ. That I wait until we're in the encounter.
All right, thank you. Now this question is about RAMP, resources for advancing mental health in pediatrics. Are practices allowed to put that RAMP website on their pediatric website? Or do you think it's more for providers, a provider-facing reference?
Julie, I can answer that one, actually. That's already been put on some other websites from some people. All it is a link to, because it is shared with consumers and with referring pediatricians. So it's my understanding that on certain websites, people have already put the RAMP link on theirs. So I think that should be fine.
And I just want to highlight some of the videos are really, really helpful. They're also available in Spanish as well, some of the written resources as well. And yeah, I just think the curriculum, if you don't have time to sit and watch all the modules, it's really nice that they created like transcribed worksheets that kind of summarize each one of them. So I definitely would put in a plug for that.
Yeah, it's a great resource. About at least 12 different curriculums are on there. So we're so happy to be able to offer that now for our providers. And then we have one more question. Is there an evidence base that shows that safety planning is effective?
There is for safety planning. I thought you were going to ask for universal suicide screening, and that is something that we're actually, that we don't have good research on yet, primarily because it hasn't been implemented in many settings. In side note, the U.S. Preventative Task Force has still said the jury is not recommended universal suicide screening until there's more research in this vein. But there is some data around safety planning as a prevention, and I don't have literature off the top of my mind, but if you email me, I'll certainly be happy to give you some of those studies.
Thank you. I think that about wraps it up for questions.
Yeah, looks like that's all the questions for the day. Thank you for joining us today, Dr. Dr. Simon. Yeah, my pleasure. So that wraps up session 2, everybody. There was a lot of you on today, so we just want to thank you for being a part of this great series that we're offering up that's going to go through Thursday. So please join us tomorrow for session 3 at 7:30 in the morning as Dr. Greg Montalto will discuss psychotropic medication management 101. So that should be another great session for you all. And just please remember to get your questions ready, type them in the question and answer area, and we'll try to get to them at the end of the discussion. So thanks, everybody. Have a great afternoon, and we'll see you tomorrow.